A very happy afternoon, one and all. Very happy afternoon, one and all. ಎಲ್ಲರಿಗೂ ಮಧ್ಯಾಹ್ನದ ವಂದನೆಗಳು. ಇಲ್ಲಿ ನಾವು ನೆರೆದಿರುವಂತಹ ಕಾರ್ಯಕ್ರಮ ಕೋವಿಡ್-19 ಸೆನ್ಸಿಟೈಸೇಷನ್ 2023ನೇ ಇಸ್ವಿಯಲ್ಲಿ ಏನು ಆಗಿದೆ, ಹಾಗೆ ಕೋವಿಡ್-19 ಪತ್ತೆ ಮಾಡುವ ವಿಧಾನ ಹಾಗೂ ರೋಗಿಗಳ ಹಿತಾಸಕ್ತಿಯಿಂದ ಹಾಗೂ ವೈದ್ಯರ, ಶುಶ್ರೂಷಕರ ಹಾಗೂ ಆಸ್ಪತ್ರೆ ಸಿಬ್ಬಂದಿ ವರ್ಗದವರಿಗೆ ಯಾವ ರೀತಿ ನಾವು ಈ ಒಂದು ಉಲ್ಬಣವನ್ನು, ಹೆಚ್ಚುತ್ತಿರುವ ರೋಗಿಗಳ ಸಂಖ್ಯೆಯನ್ನು ನಾವು ಹೇಗೆ ಕಡಿವಾಣ ಹಾಕಬೇಕು, ಅದೇ ರೀತಿಯಲ್ಲಿ ಹೇಗೆ ರೋಗ ಪತ್ತೆ ಹಚ್ಚಬೇಕು, ಮತ್ತು ಈ ವರ್ಷ ಬಂದಿರುವಂತಹ ಹೊಸ ವೇರಿಯಂಟ್ ಬಗ್ಗೆ ತಿಳ್ಕೊಳ್ಳೋಣ. It is my pleasure to announce the speakers for the day. We have two speakers for the day. Dr. Meghna Prasad, who is a pulmonologist in Sds Tuberculosis Research Center and Rajiv Gandhi Institute of Chest Disease. Dr. Meghna is a postgraduate in respiratory medicine and also a distinguished academician with good academics, and she is currently practicing with us. And also I would like to introduce the second speaker for the day, Dr. Karthik Adiga. Dr. Karthik Adiga is also MD Respiratory Medicine and a gold medalist from the Rajiv Gandhi University of Health Sciences, Bengaluru, and he is currently working as assistant professor in Sds Tuberculosis Research Center and Rajiv Gandhi Institute of Chest Disease. He has very good academic excellence and also very good clinical acumen in managing COVID-19 cases. With this brief introduction, let me not take much time and welcome Dr. Meghna Prasad to enlighten us about the precautions to be taken and what is the current outbreak statistics, and also a brief about the COVID-19. ಧನ್ಯವಾದಗಳು. On behalf of all of you, I welcome Dr. Meghna Madam.
Dr. Pradeep. Am I audible? A very good afternoon to everyone present here, my respected dignitaries and all the students. So today's talk is a summary of COVID-19, the current outbreak. As doctors working in a respiratory medicine hospital or nursing staff, physiotherapists, we have probably already been through 3 outbreaks which started in the year 2020 with the Delta variant, with the second wave in 2021, Omicron in 2020, Omicron 2021, and now I'm here to enlighten you a little about the new surge, which can't really be called a 4th wave as yet, but we definitely have to be prepared for what we can expect. So I will be talking about the etiology, the current JN1 report, transmission, pathogenesis and epidemiology, and Dr. Karthik will enlighten you about the clinical features and management aspect. So the coronavirus is a positive single-stranded RNA virus, and the etymology of the word corona comes from the word coronum, which means crown in Latin, because of the spike protein present in the membrane of the virus. It belongs to the order Nidovirales and the subfamily Orthocoronaviride, and classifies into 4 genera: alpha, beta, gamma and delta. So the beta coronavirus genus is further divided into 5 genera or lineages, and the genomic characterization has shown that the rodents are the probable gene sources, as well as bats, as we have so famously heard of the alpha and beta coronaviruses, and the avian species seem to be the source of the delta and gamma coronaviruses. They have become significant pathogens, as we very well know, of causing respiratory outbreaks, but they also have multi-systemic involvement. 7 human coronaviruses capable of infecting humans have been identified, and estimates suggest that as much as 2% of the population are healthy carriers of coronaviruses, and the viruses are responsible for 5 to 10% of acute respiratory infections at present. Other human coronaviruses historically, it's been reported as early as 1960, but we know of the outbreaks that happened in 2001 in the Southeast Asian countries, that is the SARS virus, as well as in 2012 in the Middle Eastern regions called the MERS virus. However, these weren't nearly as extensive as the coronavirus pandemic was, which hit us in late 2019, early 2020. So I'll just brief you about three terms that we need to know while assessing new variants: variant under monitoring, variant of interest, and variant of concern. So what is variant under monitoring? I'll just summarize what is in this slide. It is basically a virus, a variant that is with genetic changes that are suspected to affect the virus characteristics, but not to the extent that it may become an epidemiological issue or cause any significant public health bearing. And if it has a significantly large number of mutations in more than 2 countries for a period of 2 to 4 weeks, it is called a variant under monitoring. This moves on if it becomes clinically significant to something called a variant of interest, where a SARS-CoV-2 variant with genetic changes that are predicted or known to affect virus characteristics like transmissibility, virulence, antibody evasion, and susceptibility to therapeutics, and is known to cause a significant epidemiological change and impact the public health, global public health, is then called a variant of interest. A variant of concern is nothing but something that meets the criteria of variant of interest, and through a risk assessment conducted by the WHO TAG, that is the Task Assessment Group for Virus Evolution, determined to be associated with at least one of these 3 characteristics, that is a detrimental change in clinical disease severity, a change in the COVID-19 epidemiology with its burden to healthcare, or not susceptible to the current treatment that we are giving, or not responding to the vaccines that we may have previously provided. So in this table you can find statistics from week 44 to 48 of 2023, where if you see the yellow highlighted portion, you'll see that the number of cases of JN1 in percentages increased significantly from 3.3 in week 44 to 27.1 of known strains causing COVID-19 infections in 2023. And while the other strains, as you can see, are causing a decline. It's a similar slide. So what do we know? This is the executive summary that WHO came out with around the last week of December about the JN1 variant. So previously JN1 was thought to be a subvariant of the Omicron virus, the BA.1.1 variant, and tracked as part of the BA.2.86 variant, which I previously mentioned was a variant of interest. However, in recent weeks, due to the immense surge where it increased from 3 to 27% in 4 weeks, JN1 has been on its own called a variant of interest. And let me just summarize what's mentioned here. The risk assessment group basically said that while we should be concerned about the implications that this virus will have in terms of the number of cases emerging, it will not pose to be a significant public health problem, and we may not expect severe disease process caused by this virus. So the first case reported was around August. It was, I believe, in Luxembourg, and they found that the JN1 virus has an additional L455S mutation in the spike protein, and the cases have been reported predominantly in European countries and the United States of America, and while India is also now showing an increased surge. And again they came to the conclusion that while the data is as of yet limited, there is no significant increase in the severity of the disease process as compared to the Omicron virus. So this basically gives us a risk evaluation and stratification. Like you can see, they mentioned it as low here based on its genetic features. The growth advantage is definitely high because we saw an incredible surge of cases, but the antibody escape and the severity and clinical considerations may not be a cause for concern as of now. So going back to basics, this is especially for the students who may not have been through the COVID pandemics. COVID is as we know, transmitted predominantly via a droplet infection from close contacts or direct transmission from pre-symptomatic, asymptomatic or symptomatic individual, and it's also transmitted in aerosol generating procedures. We've also found that it can be transmitted by fomites, that is if it's present on structures, and it's been isolated on structures in the hospitals like tables, patient side bed handles, all of these structures. And vertical transmission and fecal-oral transmission have also been reported, albeit rare. What is the pathogenesis of the SARS-CoV-2 virus? Structurally and phylogenetically similar to the SARS-CoV virus that we knew of earlier, the MERS COVID virus, and it has four structural proteins: the spike protein, membrane envelope protein, glycoprotein and nucleocapsid protein, and contains 16 non-structural and 5 to 8 accessory proteins. It's the spike protein which is what gives it its name, called coronavirus, which makes it resemble a crown and is located on the outer surface of the virion. It is the spike protein that undergoes cleavage into an N and a C terminal, and which also contains a receptor binding domain, which then helps it integrate into the host cells through the receptor binding domain and then cause the virus host cell fusion. And it is actually this receptor binding domain and the N-terminal domain which facilitates the viral entry into the host cell. Significance here being this is the target for neutralization by the vaccines that we provide. So like I mentioned, so the COVID virus itself, this receptor binding domain has a propensity to bind to the human ACE2 receptors, that is the angiotensin converting enzyme 2 receptors. So any organ that possesses cells that contain these receptors have a propensity to be infected by the COVID virus. Predominantly, where we know, being respiratory physicians, it's present in the alveolar epithelium, but also in the upper esophagus, enterocytes, proximal tubular cells of the kidney and urothelial cells, therefore causing multisystemic damage. And once the virus attaches itself to the host cell, it is primed by a TMPRSS2 receptor that is present on the host cell that helps cleave the spike protein and integrate fusion. So this is just a basic diagram explaining the same. In the early phase of the infection, viral replication just causes viral related tissue damage, but what happens very worryingly in COVID is there's an immense host cell trigger response initiated, which causes recruitment of T lymphocytes, monocytes, neutrophils, cytokines and chemokines, which if it escapes what we call immune evasion happens, it results in something called a cytokine storm. So this is a diagram explaining the same. Here you can see the virus has bound itself to the host cell, integrated, nuclear fusion has happened, there is initial cytotoxic damage, secreting of the inflammatory cells as well as cytokines and chemokines into circulation. It causes leakage and vascular permeability, causing an immense influx of these cells into circulation, which eventually causes multisystemic involvement and something called the cytokine storm. So multiple extrapulmonary effects have therefore been noted, like myocarditis, acute coronary syndrome. As we have heard, there are so many events of sudden cardiac death happening in cases in patients under the age of 45 that have been unexplainable, other than the fact that it could have been a post-COVID complication. It can also cause leukopenia, thrombocytopenia, prothrombotic workup, a prothrombotic state, which is why we have seen so many cases, especially in our hospital probably, of unexplained deep vein thrombosis, pulmonary thromboembolism, myocardial infarction, CVAs. So these are the extrapulmonary effects. As you can see, it can affect all organs. A little bit about the epidemiology of COVID-19. As so far, this is from December 24, 2023. As of then, there were about 773 million reported cases of COVID-19, where India fell in the third place of the number of cases reported. And in 1 week of the last week of December, they reported as many as 2.5 lakh cases, predominantly from Europe. And in India at present, currently there are 4,000 odd active cases. Karnataka has around 1,159 active cases, falling second to Kerala, which has 1,249, so it's a cause for concern. And in our hospital, right now, as of now, from statistics of November and December, we've had totally 36 COVID positive admissions. Some were incidentally COVID positive, while some came with symptoms of ILI. 2 of the patients had severe pneumonia. Total ICU cases we've had thus far were 11, and the total number of COVID deaths were 3. So these are the COVID peaks that we know of, the highest one being in 2021, that is the second wave, and the timeline of some COVID related events in India starting Jan 20th, which is the first wave, to Jan 14th, a year later, where the immunization began. I invite Dr. Karthik now to talk about the clinical features and management, as well as the vaccination and prevention aspects of COVID-19.
So coming to the clinical features of COVID-19, so it takes approximately 5.1 days for the COVID-19 to set as an infection. It patient starts presenting symptoms after 11.5 days after the infection of the virus. So are all COVID infected individuals symptomatic? The answer is no. Around 17.9 to 33.3% of the cases remain asymptomatic. They won't have any symptoms of COVID-19, but they will be infected with COVID-19. So if they are symptomatic, then what are the most common complaints? They come with complaints of typical fever, cough and shortness of breath. And it's not just that, since the AC receptors are present in various systems, they also can present with other multi-system features like vomiting, diarrhea, anorexia, ageusia, malaise and diarrhea. So based on the symptoms and the severity with which they present, the WHO has classified COVID-19 clinical severity into 5 stages. The first being asymptomatic and the pre-symptomatic one, mild illness, moderate, severe and critical illness. So asymptomatic ones, as I already told, was they are clinically infected but they don't present with any symptom of COVID-19. Mild illnesses are those with COVID-19 infection and have mild features of myalgia, fever, sore throat, cough, diarrhea and vomiting. Moderate illnesses are those patients who are positive for COVID-19 and have evidence of respiratory tract infection and their oxygen saturation is more than 94%. Severe patients are those who are COVID-19 positive with respiratory infection and saturation of less than 94%. Whereas critical illness means that along with COVID-19 positivity, they have respiratory failure, shock and multi-organ dysfunction. So this is the WHO clinical severity that they have classified. Asymptomatic and mild disease are classified under non-severe cases. Severe means to say that the oxygen saturation is less than 90% improvement. Critical is one with respiratory disease along with multi-organ dysfunction, respiratory failure or shock. So we keep telling about ILI and SARI. What is this ILI and SARI? The WHO in 2014, when there was an influenza outbreak, they had defined influenza-like illness as an acute respiratory infection with a measured fever of more than 38 degrees centigrade, cough, and the onset should be acute, that is onset of within last past 10 days. So what is a severe acute respiratory infection or SARI? It is an acute respiratory infection along with a history of fever more than 38 degrees centigrade, cough and acute in onset of symptoms of duration of less than 10 days and it requires hospitalization. So they are classified as SARI cases. So WHO has defined who is a suspect of COVID-19. When should we suspect a case of COVID-19? So a patient who is meeting the clinical criteria of acute onset fever and cough, that is ILI symptoms, or he has any other system manifestations like malaise, coryza, dyspnea, nausea, diarrhea, or epidemiologically he is linked or contact of a probable COVID-19 cluster. Or he can be any patient with SARI. Any patient fulfilling the criteria of SARI should be a suspect of COVID infection as well. Who is a probable case of SARS-CoV? So a patient who meets the clinical criteria and is a close contact of a confirmed case, or a patient who is like dead patient with ARDS with no other diagnosis proven at the time of death with ARDS. Such a patient can be considered as a probable case of SARS-CoV infection. Then confirmed is when the patient has NAT positive, that is our RT-PCR positive or antigen detection positive, and he may or may not have symptoms. As I already told, there are 70 to 30 patients, 30% of the patients who do not have any symptoms. So, what are the testing strategies that are currently being followed for COVID-19 testing? This is the December 20 update of the CDC, Center for Disease Control. So, they recommend that for diagnosis of SARS-CoV infection, the NAT test, the nucleic acid amplification test, or the RT-PCR that we conduct is the gold standard test that has to be conducted. If the NAT is not available, then antigen detection tests, that is the rapid CAR test, can be followed. However, the antibody testing should not be carried out as a test of diagnosis or as a test of vaccine monitoring. So, there was a tests which were being conducted during the first and second waves of COVID called the antibody testing, measuring of the antibody titers by antibody tests. So, those tests are not recommended anymore for the diagnosis or vaccine monitoring by the WHO or the CDC currently. So, a little bit about the therapeutics of COVID-19, how the treatment of this COVID-19 has seen a living change. So, it started from nothing and it has grown so much. The research in COVID-19 has grown so much today. There are around 180 trials being conducted all over the world for therapeutic trials of COVID-19. So currently in November 2023, the WHO came up with a living guideline on treatment updates for COVID-19, and the following drugs were recommended. So the ones with strong recommendation for non-severe cases were ritonavir and nirmatrelvir, and for severe and critical cases were corticosteroids, IL-6 receptor blockers and baricitinib. And conditional recommendations were in favor of use of remdesivir, molnupiravir and remdesivir for severe and critical cases. So what is not recommended? There are few drugs which are currently not recommended. For example, corticosteroid for asymptomatic cases or mild cases, and drugs like ivermectin, convalescent plasma and tofacitinib for severe cases. And there is strong recommendations against the use of sotrovimab, ivermectin, colchicine, hydroxychloroquine, which we used previously, lopinavir, ritonavir combination, and antibody cocktails like casirivimab and imdevimab, which came in between around the second wave of COVID-19. They are all strongly they have a strong recommendation against the usage of such drugs in COVID-19. So currently, what is in the pipeline? So currently only two drugs are in the pipeline for development of treatment. One is the heparin, which we have been using for anticoagulation, that is being tried for therapeutics of COVID-19, and the trial is underway. And one more drug is the simvastatin, which is used for dyslipidemia management, is being used as is under preclinical evaluation for treatment of COVID-19 since the November 2023. So considering all these research and all that, the government of India has given some guidelines for the management of actual COVID-19 cases in India. So the All India Institute of Medical Sciences and the Indian Council of Medical Research, the joint task force, has come up with a guideline for the management of COVID-19, how we should manage COVID-19 in our hospitals. So our Indian guidelines say that we have classified the COVID-19 cases into three groups: the mild disease, moderate disease and severe disease, basically on the lines of WHO itself. And as we see here, the moderate disease and severe diseases are the ones which require hospitalizations. And mild disease can be managed by home isolation, and for management of mild disease, the AIMS has given guidelines like this: physical distancing, indoor mask usage and hand hygiene. Symptomatic management of fever like paracetamol and antitussives monitoring of monitoring of body temperature and oxygen saturation by pulse oximetry, and someone should be in contact with them. So we have had telemedicine for monitoring of asymptomatic or mild cases of COVID-19 before, so that has to be done. And during any phase of management, if there is any abnormality in the hemodynamic status or the oxygen saturation of the patient, then it should be brought to the immediate notice of the medical attendant. So for moderate disease, what is the recommendation? So the target saturation should be 94 to 96%, and if they are a chronic lung disease patient, then the target saturation should only be between 88 to 92%. And the ideal mask for the delivery of oxygen is non-breathing devices, NRBM mask, and awake proning is encouraged in all patients. And regarding the anti-inflammatory therapy, the steroid, the dexamethasone 6 mg per day and equivalent dose of methylprednisolone 32 mg in 4 divided doses, usually for 5 to 10 days. And once he comes out of the severe phase, then he can be switched to oral route. And then prophylactic anticoagulation, we can use heparin or the low molecular weight heparins like enoxaparin 0.5 mg per kg per day. And we have to monitor them every 48-hour. Lab testing should be done. What all should be sent? CRP, D-dimer and blood sugar to be monitored every 48 to 72 hours. Complete blood count, renal functions and liver functions should be monitored every 24 to 48 hours. And serial chest X-ray should be taken to see if there is radiological worsening of the disease, and in case there is any radiological worsen, then HRCT should be advised. So additionally, in moderate to severe cases with high risk of progression, we can use remdesivir. Remdesivir, as you all know, it is given only for 5 days. More than 5 days is proven not to be beneficial if given for prolonged durations. And initially started as a bolus dose of 200 mg IV on the first day, followed by 100 mg over the 4 days. But the condition is that a patient in home isolation cannot get remdesivir. He should be hospitalized to give remdesivir. And it should be started within 10 days of onset of symptoms, otherwise there is no use of starting. And not to be used in patients who are not on oxygen support or in home settings. And those who are receiving remdesivir, such patients, renal functions and liver functions should be monitored. So who are the patients who are like high risk for severe disease or for mortality? Elderly patients more than 60 years, underlying cardiovascular disease, ischemic heart diseases, diabetes or immunocompromised states, active tuberculosis, any chronic lung, kidney or liver diseases, previous history of stroke, obesity, or if the patient has not received any vaccination. These are the high risk cases for clinical progression of the disease. And what should we not use? So as we saw in the WHO trials, we are currently not recommending lopinavir, ritonavir, hydroxychloroquine, ivermectin, convalescent plasma, neutralizing antibodies, molnupiravir, favipiravir, azithromycin, doxycycline, which were all being used once, are currently not recommended by the Indian guidelines. For severe cases, we use NIV by helmet or face mask, and we also consider HFNC as the case may be. Intubation should be prioritized. Awake prone ventilation is promoted in such patients, and vasopressors are used if the patient is hypotensive. And anti-inflammatory therapy, as I already said, it is dexamethasone which is preferred, 6 mg per kg per day, and or it can be methylprednisolone 32 mg in 4 divided doses, which can be given over 5 to 10 days duration, followed by, if there is clinical improvement, then we can switch it over to oral. Prophylactic anticoagulation of heparin and low molecular weight heparin, like enoxaparin 0.5 mg per kg per day via subcutaneous route, should be given, provided there should be no contraindication or any active bleeding diagnosis in such patients. Also, supportive care should be given to the patient in terms of nutrition, maintenance of euvolemia, treatment of sepsis and septic shock. Again, the lab tests, every 48 to 72 hours we have to send CRP, D-dimer and blood sugars, and complete blood count, renal functions and liver functions to be monitored every 24 to 48 hours once. Additionally, in rapidly progressing moderate or severe disease, tocilizumab can be used within 24 to 48 hours of onset of the severe disease. If they are brought into the hospital within 24 to 48 hours, tocilizumab can be given. So, having dealt with the treatment aspects, we will move on to prevention aspects. So, we will see what are the statistics pertaining to the vaccination status. So, as you all know, the COVID-19 vaccination rolled out in 2021. There are around 183 vaccines in the clinical development phase and 199 vaccines under trial in the preclinical evaluation phase. And out of which the majority of them are protein subunit vaccinations and viral vector vaccinations. So what are the vaccines that are available in India? As you all know, Covishield and Covaxin were the first two vaccines that were introduced, and later they started issuing Sputnik 1, Corbavax for usage. So they all came into being in 2021. And later, in later phases of 2021 and 2022, Moderna, Johnson & Johnson's ZY-COVID, Covax and Sputnik Light was approved for use. However, Moderna order was cancelled in late 2022, and the currently available are only 4: the Covishield, Covaxin, Sputnik and Corbavax. If we see the vaccination status in India, the majority of them, 174 million patients, have received Covishield vaccination. Covaxin has been received by 36 million people, and others have received Sputnik, Corbavax and Covovax. So what are the preventive strategies that we can follow in hospital settings? So infection prevention and control in the context of COVID-19, a guideline was issued in the December 2023 by the WHO, and it had two separate wings, one for the healthcare setting itself and one more for the public health. So what we are going to see today is for the healthcare settings. So in the healthcare settings, what are the precautionary measures that we have to follow? Pertaining to the ventilation of the rooms and wards that are used for managing of COVID-19. So if we are using a room for airborne precaution rooms, like if we are giving nebulizers, doing spirometry or bronchoscopy, then they should have they should be well ventilated, like 160 liter per second per patient should be the air exchange per hour. And if it is a general ward or outpatient department, then it should have an air exchange of 60 liter per second. And if we are people who are handling COVID-19 patients in triage, registration desk and the emergency department and the pharmacy window, we should consider physical barriers such as glass or plastic window for distancing from them. And physical distancing, as we all know, maintaining of a physical distance of at least 1 meter between the patient and among the patients and the staff is recommended. It's a good practice statement. Mask use, WHO suggests that the targeted continuous medical mask use in healthcare facilities is recommended. However, when in contact with the patient of COVID-19, it is mandatory to use the mask, and in the areas where there is no active infection or we are not handling the patient, it is not mandatory to wear the mask. So, but when we are handling, taking the swab, managing the patient or in the OPD and the triage areas, it is compulsory to wear a mask. Again, PPE section, appropriate mask fitting should always be ensured. So just wearing the mask is not sufficient, appropriate fitting should be ensured, and seal check should be performed. And whenever we are handling COVID-19 patients in their wards or ICUs, PPEs are recommended, and it is a good practice statement. So what are the precautions that are being given by the WHO regarding aerosol generating procedures? Most frequently the nebulizations, spirometric testings and bronchoscopy suites. WHO suggests using airborne precautions while performing aerosol generating procedures based on risk assessment when caring for patients with COVID-19. A respirator should always be worn, and along with the PPE who are caring for COVID-19 patients. Environmental cleaning. For COVID-19 patients, the healthcare setting should use standard precautions for the cleaning and disinfection of the environment and other frequently touched surfaces, because as we have already seen, fomite transmission is possible for COVID-19. Regarding waste management, healthcare waste generated from care provided to suspected or confirmed COVID-19 patient should be segregated according to the existing guideline for disposal and whenever necessary treated as per the national local regulation policies. Operation theatre, WHO suggests that the designation of specific operation theatre for patients with suspected or confirmed COVID-19, especially in those who are handling labor and labor rooms and cesarean sections, they should have a separate operation theatre reserved for COVID-19 positive patients. So, this one thing is important: duration of isolation for COVID-19 cases in healthcare workers. So, we suggest 10 days of isolation for for individuals who are symptomatic due to COVID-2, the SARS-CoV-2 infection. And they suggest that 5 days of isolation for individuals who are asymptomatic with SARS-CoV-2 infection. So, SARS-CoV-2 infection with symptoms, 10 days of isolation, and 5 days of isolation for patients who are asymptomatic. And in such patients, for monitoring, we can use rapid antigen detection tests. So, as long as we follow these precautionary measures, I don't think this COVID-19 is going to burden us a lot. So, we should always be in our safety, that we should maintain a distance of at least 1 meter from others in any public place for that matter, and clean hands, hand hygiene is mandatory. And whenever you are in a public place, especially the elderly group with comorbidities like diabetes and hypertension, we should always encourage using mask in public places. Thank you.
Thank you so much, Dr. Meghna madam and Dr. Karthik sir, for enlightening us about the JN1 variant of COVID-19. So, right from the outbreak in 2020 and what is the story been and what are the variants and all these insightful important informations and how to prevent it and what to do, what not to do. Briefly and very comprehensively told to us. Thank you so much, Dr. Meghna madam and Dr. Karthik sir. On behalf of the director sir and all the professor and HOD Pulmonary Medicine and all the doctors and all the staffs of Rajiv Gandhi Institute of Chest Disease, we thank you so much, and stay safe, stay healthy. Thank you so much.